Welcome. In this lecture, we'll be discussing the different types of brainstem strokes. Before going over the strokes specifically, let's first break down the brainstem. We'll first discuss the different structures, including nuclei and tracts, as well as their locations within the brainstem. We'll then discuss the different types of vasculature which supply these structures. We will then finish the lecture with the different types of brainstem strokes that you need to know for your exams. The brainstem has three primary structures. The most superior structure is known as the midbrain. This is followed by the pons, and finally the most inferior structure is the medulla. This then turns into the spinal cord. This will be the diagram that we will be using for the remainder of this lecture. So let's label the structures. The brainstem has a large number of different functions, but one of these functions is that it actually houses many of the cranial nerves, specifically cranial nerves 3 through 12. Cranial nerve 1, which is the olfactory nerve, is located on the underside of the frontal lobe and connects to the olfactory bulb. Cranial nerve 2, the optic nerve, is actually part of the brain itself and arises from the diencephalon. Thus, both cranial nerve 1 and cranial nerve 2 are found outside of the brainstem. In order to organize the brainstem, we can use something known as the rule of fours. What this means is that we have 4 cranial nerves that are found either in the midbrain or above. These will be cranial nerves 1 through 4. The next 4, cranial nerves 5 through 8, will be found in the pons, and the remaining 4, 9 through 12, will be found in the medulla. These can be further categorized by location as either being medial or lateral. The way that I've always remembered the medial structures, or the medial cranial nerves, is if they cleanly divide into the number 12, then they are located in the medial aspect. So let's look at the midbrain. We know that we have 4 cranial nerves, 1 through 4, that sit either in the midbrain or above. We've already established that both cranial nerve 1 and cranial nerve 2 are located outside of the brainstem. Thus, only cranial nerve 3 and cranial nerve 4 are located in the midbrain. Both the number 3 and the number 4 can be cleanly divided into 12. Thus, they are medial in location. In the pons, we have 5, 6, 7, and 8, the next 4. Out of those 4, only cranial nerve 6 divides cleanly into the number 12 and is thus medial. In the medulla, 9, 10, 11, and 12, the last 4, only the number 12 divides into itself, and that is thus located in the medial aspect of the medulla. The remaining cranial nerves in the pons, 5, 7, and 8, are going to be located in the lateral aspects. And in the medulla, 9, 10, and 11 are also going to be located in the lateral aspects. Thus, this is how the brainstem organizes their cranial nerves, based off of if they're located in the midbrain, pons, or the medulla, and if they're located either medial or laterally. Here is a quick table highlighting the basic functions of these cranial nerves. I will not go over this in detail, but I do want to bring your attention to cranial nerve 3, cranial nerve 4, cranial nerve 6, and cranial nerve 12. The ones highlighted in red here are all motor nuclei. All the ones that are primarily motor are found in the medial aspect of the brainstem. Please note that cranial nerve 11 is also primary motor, though it is debated if cranial nerve 11 is actually even a cranial nerve, since the spinal part of the accessory nerve actually arises from the cervical spinal cord, between C1 to C5 or C6, not from the brain or the brainstem. Thus, the ones that are all purely found and started in the brain or brainstem and are all purely motor are found in the medial aspect of the brainstem. Now, let's talk about other medial structures that can also be found in the brainstem. There are 4 primary medial structures. The first one are the motor cranial nerves, which we've already talked about, 3, 4, 6, and 12. The next is the motor pathway, such as the corticospinal tract, which does most of the movement on the contralateral side of the body. The medial longitudinal fasciculus, which connects one of the cranial nerve 6s to the contralateral cranial nerve 3s. This is talked about in more detail in our lecture on multiple sclerosis. And of course, the medial lemniscus, aka the DCML, which does vibration and proprioception. All of these tracts are located medially, and they all start with the letter M. Now, here are the primary functions, as well as what happens when these tracts are damaged. The MLF, as we've already mentioned, will cause something known as intranuclear ophthalmoplegia, or INO. This will happen on the ipsilateral, or on the same side that the lesion is damaged. What happens here is you have the inability to adduct the ipsilateral eye. So whatever side the MLF is damaged on, let's say the left side, then the left side cannot adduct. It cannot go towards your nose. The motor cranial nerves, which we've already talked about, and this is how they would present if damaged. The corticospinal tract, which is primarily voluntary motor control. This causes contralateral weakness or hemiparesis. And you typically see upper motor neuron signs like hyperreflexia, spasticity with this. The medial lemniscus is also located medially. This carries fine touch proprioception. Thus, damage will cause contralateral loss of vibration and proprioception. It's important to know which ones are ipsilateral and which ones are contralateral. Now that we've talked about the medial structures, now we need to talk about the lateral structures, or as I like to remind myself as, the side structures. The reason why I like to remember them as the side structures is because they all start with S. We have the spinal thalamic tract, which does mostly pain and temperature. The sympathetic chain actually runs along the brainstem. Damage to this can cause ipsilateral Horner syndrome. The spinocerebellar does exactly what it sounds like, connects the spinal cord to the cerebellum, thus is important for balance. And of course the spinal trigeminal, which gives sensation to the face. Placing this here, we can see that all of the side structures all begin with S. All of the medial structures all begin with M. And here is the functions as well as how they would present if damaged. The spinal thalamic tract will have contralateral loss of pain and temperature. The spinocerebellar tract will have ipsilateral uncoordination or ataxia. The spinal trigeminal tract, which supplies sensation to the face, will have ipsilateral facial pain and temperature loss. Please note that the spinal thalamic tract also does pain and temperature, but that does it to the body, the lower extremities and the upper extremities. And of course, the sympathetic fibers, which damage will cause an ipsilateral Horner's, which will present with a droopy eye, a constricted eye, and inability to sweat on that side of the face. So, in summary, this is the structure of our brainstem. We have our medial structure, our medial tracts with our medial or motor cranial nerves. We have our side structures with our tracts located laterally, as well as their cranial nerves. Now that we've organized this, now let's quickly discuss the vessel territories. Now we've already discussed the anterior circulation. We will now discuss the posterior circulation. The brain is supplied by something known as the circle of Willis. And the circle of Willis supplies or connects the posterior and the anterior circulation. The anterior circulation comes off of the internal carotids, and that forms your anterior cerebellar arteries and your middle cerebellar arteries. This is discussed in another lecture on strokes. The posterior circulation comes from the vertebral arteries, and this supplies your brainstem. Thus, we will only cover the posterior circulation. The first arteries that we'll talk about are the vertebral arteries. These are two arteries, bilaterally, that come off of the subclavian artery. And off of the vertebral artery, we have two other arteries. We have an artery that actually goes down. This is known as the ASA, or the anterior spinal artery, and supplies, thus, the anterior spinal cord. And we also have the posterior inferior cerebellar artery, or the pica artery, which supplies lateral structures in the brainstem. The vertebral arteries come together and form a larger artery that goes over the pons, known as the basilar artery. Off of the basilar artery, we have something known as the anterior inferior cerebellar artery. This supplies the lateral structures of the pons. We also have something known as the superior cerebellar artery, which is really too small to primarily supply any aspects of the brainstem itself. Instead, the basilar artery gives up much larger arteries, known as the posterior cerebellar artery, or the PCA. This is our posterior circulation supply to the brainstem. So how exactly does this compare? So here's our rough outline of our brainstem. And when I put my vasculature right over it, we can see what exactly is supplying what. Let's start with the midbrain. The midbrain is primarily supplied entirely, both medially and laterally, by this large artery right here, known as the PCA, the posterior cerebellar artery. The pons, as we can see, we have a large artery going right over the medial aspect here. This is known as the basilar artery. The basilar artery supplies the medial pons. The lateral aspect of the pons is going to be supplied by these structures that are going laterally. The ICA, the anterior inferior cerebellar artery. And then, of course, in the medulla, we have two structures that can supply the medulla medially. That will be the ASA, the anterior spinal artery, and these large vertebral arteries. And then, of course, off of it, we have the pica, or the posterior inferior cerebellar arteries. It is important to know these structures. This is how I've always remembered my vascular territories. If, let's say, we have damage to the lateral pons, or the ICA here, I know that this is going to present with cranial nerve 5 palsy, cranial nerve 7 issues, cranial nerve 8 issues. It's also going to be presenting with all of these side tracts that we've already talked about. Thus, knowing or understanding this slide is extremely helpful and extremely important for test day. Now, I've included the vessel territories on paper just for completeness sake, but this is everything we've already talked about. Now let's talk about the specific types of brainstem strokes. The general rule is that when symptoms present on opposite sides of the body, it suggests a brainstem stroke. Example being, if I have loss of pain and temperature on the right side of my body, but loss of pain and temperature on the left side of my face, that would suggest maybe a brainstem stroke. Or if I have motor weakness on the right with loss of facial sensation on the left, that would also suggest a brainstem stroke. You have symptoms on bilateral sides of the body, not just on one side of the body. Now, these are going to be the primary brainstem strokes that we discuss in this lecture. So let's first begin with what is known as lateral medullary syndrome, aka Wallenberg. So lateral medullary is exactly what it sounds like. It is damage to the lateral medulla, seen out here. Well, we already know that the posterior inferior cerebellar artery supplies that structure. This is the pica right here. So I'm going to get cranial nerve 9 issues, 10 issues, and more often than not, cranial nerve 11. Although remember, cranial nerve 11 is not just purely brainstem, it also comes off of the cervical spinal cord, thus it is not always damaged. I will also get spinal thalamic issues, sympathetic, spinocerebellar, spinal trigeminal. So how's this going to present? Well, I'm going to have contralateral loss of pain and temperature because of the spinal thalamic issues. I'm going to have an ipsilateral Horner syndrome because of the sympathetic damage. I'm going to have ipsilateral facial pain loss because of damage to the spinal trigeminal nerve. I'm also going to have ataxia because of damage to the spinal cerebellar issues. Any lateral stroke in the brainstem will pretty much always have these 4 things. Thus, what separates them from one another, from the pons versus the medulla, is going to be the cranial nerve abnormalities that also come with it. Dysphagia, dysarthria, hoarseness. These are all associated with the palate, which is supplied by both cranial nerve 9 and cranial nerve 10. If this was the lateral pontine stroke, then I would have hearing issues or tongue issues, cranial nerve 7, or facial changes due to damage to cranial nerve 5, 7, and 8. Lateral medullary stroke is going to affect the lateral medulla, which will be 9, 10, and 11. The next one will be the medial medullary stroke. This will be damage right here in the medial aspect. This is going to cause issues from the vertebral artery or the anterior spinal artery. Remember, it has dual supply. And it's going to have issues with the MLF, the motor tract, the medial lemniscus, and the motor cranial nerves. I do want to emphasize with the MLF, typically this is only seen with issues in the pons and up, because this connects the cranial nerve 6 to the contralateral cranial nerve 3. Thus, typically in a medial medullary stroke, except for some rare variants that may exist out there, we typically don't have any issues with the MLF. It'll just really be these 3. So how does this present? Well, we're going to have contralateral weakness, which usually spares the face, and that's because we are affecting the motor tract, the corticospinal tract. We also have contralateral loss of vibration and proprioception. Well, the reason is because we typically have damage to this medial lemniscus. So you should know that the medial strokes are almost always going to present with these two symptoms. What differs is what is the motor nuclei doing. In this case, since I'm affecting cranial nerve 12, I will have an ipsilateral tongue deviation. We will go through the rest of the strokes relatively quickly now. The lateral Pontine stroke, so damage out here. This will be damage to the anterior inferior cerebellar artery. This will present with all damage to all these structures. So I have sympathetics, ipsilateral Horner's, contralateral pain and temperature because of the spinal thalamic tract, ataxia because of the spinal cerebellar tract, ipsilateral loss of pain and temperature on the face because of the spinal trigeminal. All these four are the exact same thing I just said for the lateral medullary strap. The only thing that differs is what the cranial nerves are. The cranial nerves are going to be facial issues, vertigo, decreased salivation, loss of taste, maybe some hearing changes because cranial nerve 8's involved, facial paralysis, cranial nerve 7, cranial nerve 5, cranial nerve 8 also plays a role in vertigo. All of these are saying that this is 5, 7, and 8. Medial Pontine is going to be damaged right here. The medial Pontine is due to damage from the paramedian branches of the pons. Paramedian branches of the basilar artery. These are very little arteries that come off of the basilar that I have not even put into the diagram. This is not the exact same thing as locked-in syndrome. And the reason being is because this only affects a unilateral side. Only one side is going to be affected. So you're going to be damaging, in this case, the right paramedian arteries. Okay, so this only affects one side. The symptoms here are going to be ipsilateral cranial nerve 6 palsy, because that's my motor nuclei, and or INO. The reason being is because, remember, the MLF connects cranial nerve 6 to the contralateral cranial nerve 3. You're also going to have your motor tracts going to be affected, so you're going to have contralateral weakness, and your medial lemniscus is going to be affected, so you're going to have contralateral vibration and proprioception changes. Now, medial Pontine stroke is not the exact same thing as locked-in syndrome, and the reason being is because it only affects one side. Instead, locked-in syndrome is due to bilateral ventral pons lesions, and this is due to a basilar artery stroke. Basilar artery. The full artery is damaged. Thus, both the right and the left medial pons is going to be damaged. This presents with damage, again, to that motor tract, the corticospinal, all those motor tracts. Thus, you're going to have complete quadriplegia. You cannot move the right side of your body, and you cannot move the left side of your body because both sides are damaged. Your consciousness is typically intact here, and the only movement that you typically get is vertical eye movement and blinking. And the reason being is because these functions come from the midbrain, and the midbrain is intact. This describes locked-in syndrome, a complete occlusion of the basilar artery, where the only thing you can do is blink and move your eyes up and down or vertically. The last stroke we'll talk about is something known as the paramedian midbrain stroke, aka Benedikt syndrome. This has caused the damage to the midbrain. This is supplied primarily by the PCA. Thus, we sometimes see this in posterior cerebral artery strokes. You typically get a classic triad. You have damage to cranial nerve 3 here, so you get ipsilateral cranial nerve 3 palsy. In Benedikt syndrome, cranial nerve 4 is usually either asymptomatic or spared. You also are going to get contralateral hemiparesis. Why do we get that? Because we have damage to our motor tract. We also get a unique finding with Benedikt syndrome. This is because we have damage to something known as the red nucleus. In this case, you have a tremor with abnormal-like movements, or chorea. If you remember, like Huntington's disease, these will be abnormal, very drastic, sharp movements. Almost like your arm is just randomly going to punch the wall. That's the best way I can describe it. You may or may not also get contralateral proprioception and vibration changes due to damage to the medial lemniscus. Thus, Benedikt syndrome is very high yield to know for the exam because it presents very uniquely compared to the other medial strokes. And the reason being is because the PCA supplies such a large and vast territory of the posterior circulation because it is such a large artery. Thus, it can damage other structures such as the red nucleus here. This is a summary table highlighting what we've already discussed in this lecture. I will again emphasize, if you can break this down into your cranial nerves, medial versus lateral, and what is midbrain, pons, and medulla, and then break it down into what structures are located medially, everything that starts with an M, and what structures are located laterally, aka on the side, and everything that starts with an S there. This will be the easiest questions to get right on exam day. And that concludes this lecture on brainstem strokes.